All right, this is Gonzo Gonzalez for AskDrGonzoAnything.com, and I'm here with the one and only Marie Bunny Owens at the Fort Worth Mitral Valve Clinic. Hey, Bunny.
Hey.
So what are we doing today?
We're just going to look at a normal echo and just kind of give you an idea of what it is that we look at, where we routinely look on every adult echo. Every physician knows our protocol. They know what to expect from each echo that we do. So just kind of go over the basic routine of a normal echo.
So for those of you listening, Marie Owens, a.k.a. Bunny, is the lead echocardiographer here at the Fort Worth Mitral Valve Program. And, as a side note, Bunny and I have been working together now for what?
As long as you were in Dallas. Because I was there the same time you were. So 8 years?
Yeah. So
9 years now?
Bunny and I started probably about working together about 8 years ago. And we started a really cool program down in Dallas. And how'd you end up in Fort Worth? I honestly don't know how you ended up in Fort Worth.
I transferred over here to be the supervisor of the department.
Okay.
Yeah.
So Bunny transferred, and then I saw an opportunity about a year ago to come over here, and to my surprise, I walk in and I'm like, "Who's there?" There's Bunny, and I was like, "Bunny!" And so so that's kind of how we started. So
and I was just as happy to see you.
And that it's exciting. It was totally cool. Diana and Bunny and I started the mitral valve program here in Fort Worth, and we've been going gangbusters since. It's been a really cool journey, and a lot of people are being helped in the community. And so, in any case, so Buddy and I sit down and we kind of talk about cool cases. We review echoes when some of our partners call us up, and we take a look at it. So I figured that today, as our first podcast, we interview Bunny and we get an idea of what exactly goes on behind the closed doors of the echo department. So the questions are really simple, and just remember, there's a lot of people that may be listening to the podcast that may not know what an echo is and how do we do it, and
okay. So
that my goal is to, at least when we're talking, that at least you can give us an idea of what we're doing here in the echo lab. So, any case, as a big general principle, what's an echo?
An echocardiogram is basically an ultrasound of your heart. So if you've ever had an ultrasound of anything, when you look at a baby, look at your carotid arteries, anything, it's all the same principle. It's based on a Doppler physics principle. A sound wave penetrates into the tissue and bounces back and sends a signal, and it's a grayscale signal. Also, we can look at, by color Doppler, we look at the direction and the speed of the red blood cells flowing through the valves. That's how we can find out if there's a leaky valve. We see it by color. Also, we can measure pressures in through the valves, velocities through the valves. That gives us a lot of information about the function of a valve. So we get a lot of information from an echocardiogram. So
you said, and while we're here doing the podcast, we're actually staring at an image of an echo that was recorded on a patient earlier, and what I typically tell patients is the same thing. It's pretty much an ultrasound and the same information that we utilize to make anatomical decisions in the operating room. We kind of see it beforehand on an echo. And so it's a really good tool. We do it every day, and patients come in and if you're getting an echo here at our valve clinic, you have the opportunity of actually look at it. And, like I tell most people, that if they ask questions to the techs that are doing the echo, they know as much as most cardiologists do about the anatomy, because they're doing day out. How many echoes do you think we do a week or a month here?
Oh, a week. I would say at least 100 a week, 150 a week.
So that's about
equate to a month, yeah.
So that's actually a bunch.
It's a bunch. We do anywhere from 15 to 35 a day.
Wow. Those are pretty big numbers. Okay, so what So first of all, when you look at echo, what are the things that we can see? As soon as you put the probe on somebody, what are the things that you focus on? As
soon as we put the probe on a patient, our first image that we get, and this is in almost any echo lab, your first image is what we call a parasternal long axis. In this image, we can see the function of the left ventricle, the squeeze of the muscle of the left ventricle, gives us an idea of what we call an ejection fraction, which is the percentage of blood pumped out of the heart, of the left ventricle in one beat. And we see the mitral valve. In one plane of a mitral valve, we see the left atrium, the size of the left atrium, the aortic valve, whether it's opening or closing. Most of the time we can see the aortic root. We can see part of the right ventricle to see if it's enlarged. So basically, we see most of the function of the heart with this first image that we obtain.
And one of the cool things is that, as Bunny pointed out, you can see the two major valves on the left side of the heart, right?
Yes.
And that's kind of where they focus on initially. So most echocardiographers are trained to look at it that way, right?
Yes.
That's the first thing that they look at. And we can just see, how they're functioning. It's cool on the image right now that we have. It's a really beautiful image. You can see the mitral valve working really nicely with all its mitral valve apparatus. And because we're so focused here on the mitral valve, at the Mitral Valve Program in Fort Worth, on mitral valve pathology, it's actually a really cool image. Who did that? Who did that echo?
I think Danielle.
That's a beautiful echo.
Maybe me. It may be me.
Why don't you give kudos to Danielle? Okay. She needs a raise too. So give her a raise. That's a beautiful. Okay, so we look at the valves, and so that gives us at least the first thing is how structurally they're looking, right?
Yes.
Okay, and then what's the next thing that you do?
The next thing, we make a lot of measurements. Uh-huh. So these are just routine measurements. We have normal values for an adult.
And what things do you measure? You measure what structures do you measure?
First thing we measure is the size of the left ventricle in diastole, and then the size of the left ventricle in systole. And the machine calculates a lot of numbers and comes up with what we call a ejection fraction.
What's a normal ejection fraction?
Normal ejection fraction is 60.
Okay. And what's the normal size of the left ventricle that you see in systole and diastole on average?
Less than 5.5 centimeters.
So if you have a ventricle that's less than 5.5 centimeters, that's normal.
That's normal.
Considered normal. Okay. And how about a left atrium? Because you have the left atrium right there in front of you.
The left atrium, the normal size of that is anything less than 4.0.
4.0.
Centimeters.
Okay. And then how about the other thing that you can measure here, you're looking at right now, it's the aortic valve.
The aortic valve.
What's normal?
We measure the left ventricular outflow tract, which is it's actually the insertion of the leaflets of the annulus of the aortic valve. I know that's getting very technical, but it's the point at which the valve is attached to the aortic root. And it's called the left ventricular outflow tract. We measure that. The normal is 2.0 centimeters.
Okay. Hey, Bunny, on a side note, how long have you been doing this for?
25 years.
So you started when you were a teenager then, huh?
Of course.
All right. Okay, so then you're able to measure the size of the aorta. You're able to measure the size of the chambers. Can you also see coronary flow here? Is it a good test to look at the coronaries?
No.
Why not?
Coronary arteries are very small, and we don't see them. Occasionally, in some off angle, we can see the ostium, the takeoff of the main coronary arteries, like in a short axis of the aortic valve. We can see the takeoff, and that is actually the interesting little thing is when pediatric echoes, when we're looking for Kawasaki disease.
Okay.
You can see the beating of the coronary arteries sometimes as they take off of the
oh, that's super
aorta.
Cool.
Yeah. I've seen that once, so.
Okay, so how about the pericardium, the sac that lines the heart?
Yes.
Can you see that too?
You can see part of it. We can see this posterior section here. Here's actually the pericardium where it separates from the epicardium of the heart.
And that's also an area that you can look and see whether the patients have fluid around the heart, right?
Exactly.
So that's called a pericardial effusion.
Yes.
Okay.
Yes.
All right. What things have changed over the last since you started doing this, what has been the most significant change in echocardiography in the last several years?
Probably the most significant change in the last several years is the implementation of live three-dimensional echocardiography.
So basically,
that's been the biggest change that I've seen.
I've seen the echoes, and let me tell you, it's almost like, when you see the ultrasounds of the babies, that you basically can see how they look and their structure and all that stuff.
Yes.
We do the same thing with the heart.
Yes.
For a surgeon, I'll have to tell you something. Going from two-dimensional to three-dimensional echocardiography has been probably one of the most amazing things, because as a surgeon, for me, it can pinpoint exactly if you have pathology that it's amenable to repair. You can see it like if you were in the operating room without having to open up a patient.
Yes.
Which in the past, I remember when I took my boards, one of the images that they showed, and this was on paper. This wasn't actually on computers like we do it nowadays. Mm-hmm. I'm dating myself. But I sat down, and basically they would ask you, and they put an arrow on a photograph, and they say, well, what structure is this? And they would show you a mitral valve, and you had to figure out whether it was a posterior or an anterior leaflet.
Okay.
And so, but the cool thing about 3D has been the ability to really look at these in a way that you would be in the operating room, and planning your surgery has become incredibly easier, because you've taken out some of the guesswork that comes with 3D, with 2D imaging. And we do it also in the operating room, which, oh my God, it makes it so much easier, because when you do a TE in the operating room, you see the lesion, you're like, okay, I get it, now I can do it. And it's non-invasive. I mean, well, you do have to do an esophageal probe in the patient, but it's certainly not as invasive as you would think.
No. And that brings up a point, too, that you said an esophageal probe.
Mm-hmm.
So most of our studies are done on a transthoracic.
That's a good point, yep.
Non-invasive.
Mm-hmm.
But we
the
also have
transthoracic, you just put the probe on the chest.
Just put the probe on the chest.
And that's what most of the time we do.
And we slide it around and manipulate different angles. In a transesophageal probe, we actually have the patient sedated and numb their throat, and they swallow a probe that's about as big around as my index finger.
Why do we put it in the esophagus in the first place? Why is the esophageal approach the one that we use? Because there's no, I mean, you can do epicardial when you're in the operating room, but an esophageal, what makes the esophagus the place to put it in?
Access, for one, but then you position the probe where it is right behind the heart.
Yeah.
There's no interference.
Right.
You are right next to the left atrium.
So anatomically, when if you look at an anatomy book, you can see that the heart is basically sitting on top of the esophagus. And so when it comes to one of the things that limits the use of surface echocardiography is the fact that there's a lot of scatter that can occur because of body size, fat, and the distance that your probe is from the heart.
Air.
It's air. Usually it's easier if you're thin, right?
Yes.
In larger folks, then it becomes a little bit more of a challenging, because the probe works the most or the best when you're actually really close to the structure that you're trying to do an echo. So that's why a TEE is so good, because usually there's not a lot of fat and air or distance between the esophagus and the heart. And so basically we can just basically see the heart and see it really straight up from the esophagus.
And there's images that are deeper and positioned, the left atrial appendage being one that we can't really see in a transthoracic echo unless it's big and dilated, but you can see very clearly on a transesophageal echo. And there's instances where we need to rule out thrombus in the left atrial appendage, and that's the way to do it.
Cool. So what advice do you have to patients that come in with that have murmurs and all that stuff, that they should go see their doctors and maybe get an echo to see if they have something?
Absolutely.
Yeah.
An echo is a non-invasive. It takes 30 minutes, maybe an hour to do. It is a very simple test that gives an enormous amount of information. Cool. There's no reason not to. I mean, if it were up to me, it would be on a physical exam every year. You should get an echo. Of course, insurance isn't going to pay for that, but it is such an easy test to do, and it gives so much information. And we find things sometimes patients had no idea they had. The doctors didn't know they had. So why not?
Bunny,
why not do an echo?
thanks for taking time and talking to me today.
You're welcome.
Keep up the great work at the Valve Clinic in Fort Worth. Hey, guys, we'll